Bueno, antes de todo, muchas gracias a todos por venir. Lo haremos en castellano porque hay gente de fuera. Gracias a todos por venir. De verdad que es un honor teneros aquí para esta jornada. También muchas gracias a los ponentes. Thank you very much for coming to Girona for our symposium. Y muchas gracias también a nuestros sponsors, sin los cuales esto no podría ser posible. Tenemos el apoyo de Astelas, Promedon, Neomedic y Medical Cañada y PFM. Primero de todo, comentar que hemos tenido un par de bajas por problemas médicos. La doctora Alicia Martín no ha podido estar con nosotros debido a un problema familiar y el profesor Stefano Salvatore tampoco podrá estar con nosotros. Hemos reestructurado un poco el primer módulo y el primero en hablar será el doctor Adi Weintraub de Israel, de Beersheba. Él es el jefe de la sección de suelo pélvico y ahora es el chair de la Sociedad de Urogynecologia de Israel. Thank you, Adi.
Good morning. Thank you very much for the invitation. It's very exciting for me to be here. Can you hear me? Yeah. Okay, so this is my hospital. We have, I told my friends yesterday, we have over 17,000 deliveries annually, every year. So there's a lot of going on there. I have no conflicts to declare. We're going to talk a little bit about the definition, the prevalence, the progression of disease, comorbidities, quality of life, and economic burden of overactive bladder. And in the end, I'm also going to talk a little bit about the different available treatments without really going in depth to the mechanism, just so we know what's out there. The biggest problem with understanding the epidemiology of overactive bladder is that there's so many different nomenclature, so many different terms, and it was called throughout the history either by symptoms like nocturia or urgency, or it had all kinds of different names, which probably most mean the same thing, like urinary urgent continence, reflex incontinence, motor urgent continence, all kinds of different definitions, until the ICS, the International Continence Society, and the IUGA, International Urogynecology Society, decided to sit together and define what is overactive bladder. And it's urgency, the feeling of urgency, with or without incontinence. It could be either wet or dry. And usually it's accompanied by frequency and nocturia, but it's not a must. We should know that it has, of course, synonyms: overactive bladder syndrome, urge syndrome, urgency frequency syndrome. But we should know it's a symptomatic syndrome. I mean, we don't need to do any tests in order to diagnose, enough to hear what the patient is telling us about the symptoms in order to diagnose it. Of course, many of my colleagues that do urodynamics might not agree with me, but it's pretty much a symptomatic syndrome. Most these symptom combinations are suggestive of an underlying etiology, which is detrusor overactivity, overcontractility of the detrusor muscle. But the evidence to prove it is very, very vague. It's more theoretical, because we know that a large percent of people who have overactive bladder, we will not find detrusor overactivity, and many women that have detrusor overactivity won't suffer from the symptoms. So it's not a big overlap between the symptoms and this specific etiology. And there are many theories about the underlying etiology of overactive bladder, from microbiome and the neurogenic theory and myogenic theory and aging and many different theories. I think our biggest problem is that we don't know, and that's a challenge for treatment because we can't, pinpoint the treatment for all patients. And of course, in order to make the diagnosis, we need to prove that there's no infection or other underlying causes that explain the symptoms. When we talk about the symptoms, then urgency is the complaint of a sudden, compelling desire to urinate that is difficult to defer. Urge urinary incontinence is involuntary leakage accompanied or immediately following urgency, a sensation of urgency. Frequency is the complaint of voiding too often during the day. And we can ask how much is too often. Of course, it depends on how much we drink and what's the weather like and everything. Is it hot? Is it cold? But it's customary to define more than 8 times during the day as high frequency. And nocturia, again, is waking up from sleep in order to urinate. And also we can say how is one time waking up, is it pathological, 2, 3? Some women wake up 3, 6, 7 times a night, and they really... Obviously, it hurts their quality of sleep and quality of life dramatically. Also, so here also, it's customary to say that 2 or above awakenings during the night to urinate is considered nocturia. When we talk about the prevalence, having stated the problem that we have with the definition before, so there are actually very few large-scale population-based studies, and most of them are already pretty old. So one of them is a study that talked about the fact that, first of all, overactive bladder is existent in men and women, and in not very different percentages. The median prevalence of incontinence for women was 15 to 40% more or less, and for men like 4 to 15%. So there's even an overlap in the percentage between men and women. And of course it changes through the lifetime, and you'll see. One of the large population-based prevalence studies was from 5 European countries, including Spain, and had a 2-stage telephone questionnaire. One was screening individuals with bladder control problems, and the second stage was characterization of the urinary condition. The responders were over the age of 40, and they were included. This study included more than 16,000, close to 17,000 interviews, and 19% reported having bladder symptoms. When we talk about the overall percentage of overactive bladder, we're talking about something like between 15 and 17%. In both men and women. Close to 80% in this questionnaire had it for at least 1 year, and close to 50% were suffering from symptoms for at least 3 years. The most prevalent symptom was frequency, followed by urgency, and urgent incontinence was in over 1/3 of the patients. So we're talking about, a condition that is very, very impactful, negatively impactful on many women and on their quality of life. They also saw there that the prevalence increases with age. You can see here men in blue and women in red. After a certain age, for men, it's more dramatic than for women. Women, the slope is pretty steady. Another very important landmark study was the Nobel study, and it was a computer-assisted telephone interview of over 5,000 adults above the age of 18. Of course, in the United States, of non-institutionalized population, and they found that OAB dry, meaning without urgent continence, was defined as more than 4 episodes of urgency in the previous 4 weeks to the questionnaire, frequency of more than 8 times a day, and use of more than one coping behavior, meaning calculating where the bathroom is, using sanitary pads, or any kind of coping behavior. That was the definition of OAB dry. OAB wet was all the definitions of OAB dry plus 3 or more episodes of urinary incontinence in the past 4 weeks that were clearly not episodes of stress incontinence. Okay, and what they found is that in the USA, and this is, the Nobel study is already, today it's already a pretty old study, but back then it was 33 million Americans, adult Americans, had suffered from overactive bladder. We're talking about about 1/3 was OAB dry, and 2/3 had, one third were OAB wet, and 2/3 were OAB dry. And you can see the rates for men and women. The overall rate is pretty much similar, and we can see that when we look at the ages, there are different slopes for men and women. The dotted line with the circles in the middle is for women, and with the squares is for men. So you see that the slopes are different for men and women, but the average, when you take them all together, is the top graph. It's more or less the same. The big thing is that it affects also some women in early age and reproductive years, but it goes and increases with age. Okay, when we talk about the prevalence as compared to other very known and common diseases or conditions, it's out there between sinusitis and hypertension. Think how many people you know that suffer from sinusitis and hypertension. So OAB is right there when we talk about millions of people. Another big epidemiologic study is the EPIC study, which also showed the prevalence increasing with years. And also this was a study conducted in 5 European countries, Europe and Canada, 4 European countries and Canada. And it showed, again, the comparison between men and women. They showed, it was a study about different kinds of urinary symptoms, lower urinary tract symptoms. And we saw there that regarding the OAB symptoms, the most frequent was nocturia, of close to 50%. Another thing they found there is that these symptoms are associated very dramatically with feelings of depression and doing not so well on psychological, social and psychological performance or condition. When we think about the progression of overactive bladder, so we ask ourselves, does the severity of overactive bladder and urinary incontinence symptoms progress dynamically over time? And what are the factors that are associated with the symptom progression and or regression? Is there any regression? So the incidence of, in this study, the incidence of overactive bladder in a white population was between 4 to 9%, with urinary incontinence in general being even close to 20%, but this included also mixed incontinence. And they observed over time a dynamic progression of the severity of symptoms. When they looked at the overall rate between 1991 and 2007, more than 15 years later, the overall rate was very similar, around 10–11%, but it was not necessarily the same women. So some regressed and some progressed. Here you can see it, the OAB wet and OAB dry. From 1991 to 2007, it changed the percentages. Whoever had in the beginning OAB wet, it was much more prominent after the period, after 15 years. And those who had dry had less, the progression was less robust, but it was also very significant. And if we talk about remission, then among the OAB dry, about close to 50% of patients had complete remission, and close to a quarter, 26% had remission if they had in the initial questionnaire OAB wet. What factors are associated with the progression of overactive bladder and urinary incontinence? So we know, of course, gender, women and men, the age, race and ethnicity, parity, dietary lifestyle factors, and comorbid conditions like constipation, diabetes, obesity. All these were found to be associated with the progression of overactive bladder. And of course, the existence of overactive bladder can impact other problems, especially when we think about it, when we're talking about the old age population. So it's associated with falls and fractures in the elderly, which is, very, very impactful. It has impact on UTIs, on skin dermatitis, like diaper rashes. It's associated with isolation and depression, and sleep disturbances, of course, especially with nocturia. By the way, the focus of this year in the WHO as a global disease or global condition that has to be addressed is isolation and loneliness of people. Maybe after the COVID, but that's the main focus this year of the World Health Organization. When we talk about quality of life, then it has a profound effect on all aspects of quality of life, social functioning, vitality, general health, all the parameters that we use to measure quality of life are affected by overactive bladder. How can we measure the burden or the cost of this disease? So, of course, there's direct costs, there are consequential costs, and there's intangible costs. The direct costs, like the diagnostic cost, the treatment cost, are obvious. The indirect are lost productivity, women that stop going to work. There was a big thing in England recently about menopause and urinary incontinence, that women would prefer to stop going to work than to endure these symptoms. costs like sanitary products, treatment of skin rashes that have to do with the urinary leakage, and if we're talking about falls, about fractures, stuff like that. And there's also the intangible costs. How much, what price do we put on embarrassment? What is the price that we put on suffering? Okay, so we don't know. When we look economically, and also this is already old, it's 20-year-old data, then the cost of overactive bladder and overactive bladder wet with incontinence is somewhere between arthritis and pneumonia. Okay, so it's very, very, very common. I want to mention now a little bit about the treatment options of OAB. As I said in the beginning, we have many treatment options, and we have many treatment options. That means that there's no one good treatment that fits all. So as in many conditions, we start with lifestyle modifications, there's behavioral therapy, some medications, and then there are specialized treatments. Okay, so when we talk about lifestyle modifications, we're talking about diet, on eliminating bladder irritants like caffeine, alcohol, managing fluid intake, weight reduction, stop smoking, managing bowel regularity. All these things are lifestyle modifications that can alleviate some of the symptoms. When we talk about behavioral therapy, then modifying the bladder function by changing voiding habits, calculating before you leave home, you go to the bathroom even if you don't need, doing some pelvic floor muscle training and bladder training. When we talk about the medications, and this is maybe the mainstay, so we're talking about for postmenopausal women, local estrogen treatment can be helpful. And it's even safe among women who are breast cancer survivors. The amount of systematic absorption of vaginal estrogen is very, very minimal. Anticholinergics are the mainstay. We have the beta-3 adrenergic agonist, mirabegron, okay? And some tricyclic antidepressants that were shown to alleviate some of the symptoms. Then if a woman is refractory to treatment or cannot endure side effects that these medications may have, then we will go to specialized treatments. I don't know how it is here in Spain, but in Israel, most of them are not included in they're only private, they're not included in the public coverage. So we're talking about sacral neuromodulation, percutaneous tibial nerve stimulation, and intradetrusor injection of Botox, or botulinum toxin. And the definitive surgery is artificial sphincter implantation or augmentation surgery. So we've mentioned the lifestyle modifications and behavioral therapy, the medications, and then 2 minutes, yeah, okay. And then next, the PTNS is fine needle positioning just above the inner ankle, electrical stimulation to the sacral plexus via the tibial nerve. It's a weekly treatment for 30-minute sessions for about 12 weeks. We don't know the long-term effectiveness of this treatment, but and the effectivity is declining over time, but it has some benefits for this specific group of patients that are refractory to treatment. The next is the Botox, which is a neurotoxin produced by the bacterium Clostridium botulinum. It's one of the most lethal toxins in nature with lethal dose 50 LD50 of 1.3 to 2.1 if it's injected, nanogram per kilogram if it's injected IV or IM. It can cause botulism, which is a serious and life-threatening disease in humans and animals, and has a variety of cosmetic and therapeutic uses as well. You know that the botulism is a disease that has been described in the context of improperly handled meat products or sausage poisoning. Justinus Kerner in the early 19th century first described the botulism in cases of sausage poisoning in the end of the 17th century, and only in 1897 Emil van Ermengem managed to isolate the toxin from anaerobic bacterium, which he named Clostridium botulinum, because botulus is a sausage. Okay, what we do there is injections into the detrusor muscle, about 20 injections, and it causes a paralysis, relative paralysis of the detrusor muscle, preventing the contractions. And sacral neuromodulation, I'll skip the movie. Sacral neuromodulation also works about through the electrode that is inserted into usually the S3 sacral nerves, and gives a stimulation. We have no time for this demonstration. Okay, and to sum up, OAB is a symptom-based syndrome, affects millions of people worldwide. The prevalence increases with age. Despite the high prevalence, millions of people with OAB are undiagnosed and untreated. The definition of the ICS in the yoga we mentioned, it has considerable direct and indirect and tangible costs, both on the personal level and the healthcare system level. And we talked about the different treatment options, and thank you for inviting me to your beautiful city.